Ladies and gentlemen, dear colleagues, a warm welcome from my side. My name is Thorsten Kühn, and I'm chairman of the German branch of EUBREAST, an association that was founded in 2018 with the idea to strengthen international collaboration of breast surgeons, especially in the field of clinical research. Several large studies like AXANA or EUBREAST-1 have been initiated, and we noticed a huge interest not only of single surgeons, but also of national associations to collaborate with one another, which was our original idea to found this association. Our new project relates to implant-based breast reconstruction. As you all know, there has been a shift in recent years from two-stage to one-stage, and from retropectoral to prepectoral implant breast reconstruction. However, there's still a lack of data for these techniques that are preferred by many breast surgeons today. And at this point, I hand over to my friend Oreste, who is the PI and initiator of this trial. Oreste, the stage is yours.
Thank you very much, Thorsten, for your introduction. A very warm welcome from my side as well. Thank you all. Well, first, the International Steering Board for participating and joining today, and all the audience for being here live connected. Don't be shy, so you're actually encouraged to ask questions. So please use the question and answer button that you have in your platform. Obviously, the sooner you ask the question, the higher the likelihood that your question will be addressed either during the roundtables or during the question and answer session that we are going to have after the scheduled talks and roundtables. So with no further delay, I'm calling the first speaker. It is really a pleasure to introduce Walter Weber. Everybody knows Walter. He's the leader of the Oncoplastic Breast Consortium. He's co-chair of the upcoming St. Gallen Breast Cancer Conference. He's PI of several trials and initiatives, Taxis trial, just to mention one. So thank you very much once again, Walter, for joining the International Steering Board and for being here with us today. And Walter is going to give us an update of the ongoing randomized trial carried out by the OPBC about prepectoral reconstruction. So Walter, please.
Thank you very much, Oreste and Thorsten, for this invitation. Congratulations for your very impressive success with EUBREAST. It's a huge honor to collaborate with you and your group. Dear colleagues, thank you for your interest in the OPBC-02 PREPEC trial. Alessandra, I just see myself. Now I can see the slide. Perfect. In this trial, we are randomizing pre versus subpectoral positioning in patients undergoing implant-based breast reconstruction after skin or nipple-sparing mastectomy for breast cancer treatment or prevention. Next slide, please. In 2019, the annual OPBC, Oncoplastic Breast Consortium project used Delphi methods and the consensus conference. We had about 200 participants, experts from breast cancer surgery, breast reconstruction, radiation oncology, and many patient advocates. And during this project, we identified research priorities in the extended field of oncoplastic surgery. At this point, this included mastectomy and immediate reconstruction. And one of these research priorities was exactly this question, and we asked the best way to scientifically address this research priority. And this is what came out, and this is what we're doing now. So we recommended a multi-center superiority trial, again, randomizing pre versus subpectoral positioning. Let me just close the chat so I'm a little bit more focused. And the primary endpoint in this trial was patient-reported outcome, and we decided, based on patient advocacy, to use long-term physical well-being of the chest as assessed by the BREAST-Q as primary endpoint. The big other option is satisfaction with breasts. You can use either one. There is a little bit known about minimum important differences, so we could calculate the sample size to 372 patients. Now, at the beginning, I wanted to do this right for everyone. I have to disclose that I do not perform breast reconstruction myself. I just realized there is a lot of heterogeneity in practice, so I wanted to study this. So I wanted to get an agreement on what implants we use, what expanders, 1-stage or 2-stage, with mesh or no mesh, and what mesh, and it was absolutely impossible. And you could not believe the intensity of opinions that I received during this time and the level of disagreement among the experts. It's really a huge opportunity for research. So we decided to do this in a pragmatic way, which means you can do whatever you want to do as a surgeon. We just document everything in detail, and this allows us to generate data that are applicable to the real world setting out there. As you can see on the bottom, it's an expensive thing, 370 patients, almost 2 million Swiss francs, US dollars, euros, it's all the same today. And we received this from the most competitive funding agencies. And that's a clear sign that we're on the right track with this research. Next slide, please. And here you see the accrual curves. On top, you see the countries. It's 10 countries participating around the world. We keep including new sites, backup sites, because we went through major storms, the pandemic and several crises. But now we're almost done. We need only about 20 patients. So if you're a participant and you're listening, just include one more patient, please, and we will be done by the end of the year. Next slide, please. This is the accrual by site. You see that we have very good accrual in Budapest, Heidelberg, Basel, then several sites from Sweden. We had Buenos Aires, who came in late, but with a big, with a big entry. And the same is true for Curitiba in Brazil. But all of these sites, they do extremely well. And it's a really global enterprise. And we have big and small sites. We have private, public, academic sites, and so on. So last slide, please. And we are getting productive. We now, Jana de Bonifaz actually said, we should do an early safety, early complications sub-project, which we have now pre-specified. So Jana is in charge. We're going to start working on this soon. And then in about a bit more than 2 years, we're going to analyze and publish the primary endpoint. And we do have an extended follow-up because we also want to look at some oncologic questions to see if there's a difference between the two groups. And that's it with the update. I thank everybody very much for your attention.
Torsten, please, you want to introduce Badir, please?
Yeah. Thank you very much. So I was muted. So first of all, thank you very much, Walter. And it's my great pleasure and honor to announce the next speaker, who is Professor Bahadir Koloklu, who is chief or head of the Department of General Surgery in Istanbul, and who is also chairman of the Zenaturk Group, a very effective scientific group in Turkey. And we have so many projects running together, and he's an extremely good networker. And so it was no wonder that he agreed to participate in the scientific board, and we are happy to have Bahadir in the board. Bahadir, your presentation, please, on the landscape of clinical research on the topic.
Thank you very much for the kind introduction, Torsten, and also Oreste for giving me the opportunity tonight. Very briefly, tonight, I would like to go over the current clinical and research landscape on prepectoral implant-based reconstruction. In order to provide evidence on a particular research area, we know that the investigators should look for relevant outcomes. Recently, 2 international groups recommended almost the same outcomes when studying an intervention or an agent for breast cancer management. As the research priorities, both ETHOS and ICOM groups pointed 4 main outcome domains: efficacy, safety, cost effectivity, and patient satisfaction. Next slide, please. Also, it is underlined in ICOM group that adequate follow-up should reach up to 10 years, especially when looking for efficacy and patient satisfaction. Next slide, please. So far, there are many retrospective and observational studies on prepectoral implant-based reconstruction, each having different objectives. Also, a number of systemic reviews and meta-analyses were done on efficacy, cost effectivity, and patient satisfaction. As an overall summary, all analyses provided that the prepectoral approach seems to bring some advantages to the patients and the funders, but reminding you that none of them from a randomized study. Next slide, please. So in fact, there is one small pilot study that deserves merit here to be mentioned, which is from the UK called EUBREAST study. This is a small-scale study that registered and observed patients in a single arm, in which the patients underwent prepectoral implant-based reconstruction after mastectomy. In this cohort study, the authors aimed to explore the short-term safety of prepectoral reconstruction, and they found that the complications rates are high, but implant loss is comparable to that associated with the subpectoral implant-based reconstruction. Next slide, please. After that result, the same group started an external pilot randomized study allocating their patients into prepec and subpec reconstruction arms. With this new study, they aim to determine the feasibility of undertaking a full-scale trial comparing both approaches. But the results of this study are still pending for the time being. Next slide, please. So one full-scale randomized study is currently underway, as which Walter described just before me. What I might say as an addition to his talk is that this study's outcomes and follow-up periods are concordant with the international recommendations, which I mentioned in my previous slides. Again, as Walter stated, that its recruitment is almost finished, so we eagerly wait for its results. Next slide, please. So apart from those I showed you, there are 10 more studies that seem to be underway, and when you look at the clinical trials, aiming to understand the role of subpectoral implant-based reconstruction. 7 of them are currently recruiting patients, and among them, 4 are randomized, and others are either prospective observational cohort or single-arm studies. Of those randomized studies, 2 of them are from the US and have the same design and study arms, which is prepec reconstruction with or without ADM. The other 2 studies compare prepec versus subpec reconstruction with slight differences in their study arm design, in which they compare prepec reconstruction by either using mesh or not. And these studies are from Canada and Italy. Next slide, please. Okay, those were the so far published or current studies underway. Moreover, what I may add is that, like it was in the EUBREAST study from the UK, prepectoral approach is underrepresented in audit trials. So still we have gaps on the issue. Therefore, we definitely need more evidence for prepectoral implant-based reconstruction. There's still no prospective long-term robust data to support the oncological and technical safety, as well as the cost effectivity of the procedure. Of course, not forgetting its impact on patients' quality of life. And my last slide, please. But any further study, of course, will not be without any challenge. For instance, a randomized study may not provide adequate power to reach a solid conclusion, only if there would be a big superiority on one arm. Also, there are too many subgroups of comparison in order to rule out confounding factors effects on the findings. So it may require large sample size to exclude any of those failures. Last but not the least, the external validity of the study findings will be a great challenge, especially when considering the standardization difficulties for both the caretakers and the patient health. So that's all I may say in this short time. Thank you very much again, Thorsten, for giving me the privilege, and also Oreste. Thank you.
Great. Thank you very much for this really brilliant overview, Badia. And now I think, Oreste, you will introduce the next part.
Yep. Well, okay. Thank you very much once again. Thank you, Badir and Walter, for summarizing the ongoing and current situation about research. After hearing the last presentation by Badir, I think that probably we are in the right track. So it is my pleasure to introduce the next project initiated by EUBREAST, which is a prepectoral reconstruction in patients undergoing mastectomy for breast cancer, a prospective multicenter international cohort study. Next slide, please. So why we decided to launch this project? Well, first of all, we all agree on the fact that prepectoral reconstruction is for certain a game changer, is for certain one of the major and most important innovations in the field of breast cancer surgery. And then we have also today a big opportunity that we want to take in order to know more, because everybody is basically doing prepectoral reconstruction, but we need to know more about indications, techniques, complications, and very, very important, we need to know more about satisfaction of the patients, about quality of life issues, and about cosmetic outcome. Next slide, please. So we decided to launch this project under the umbrella of EUBREAST Network. Now we're going to discuss some administrative issues, but hopefully and probably EUBREAST Italy will be the sponsor of the study. Next slide, please. And we are really happy and honored to have really an outstanding international steering board, really, I would say a dream team with outstanding researchers in the field of surgical oncology, in the field of reconstructive and plastic surgery, in the field of patients advocacy, in the field of psycho-oncology, in the field of radiation treatment as well. So we really like to thank the International Steering Board for joining this project. And actually, in the first meeting that we had together, several major points were raised, and really the contribution of all the participants is highly appreciated, and their contribution really improved the trial. And next slide, please. Apart from bringing people together, we wanted also to bring organizations together, and this is exactly in line with the aim and the objectives of EUBREAST. So EUBREAST was born as an organization to facilitate international research on breast cancer surgery. And so now we are really happy that we have several national and international organizations supporting the trial, and you can see there in alphabetical order all the organizations which are actively participating and joining the trial. Next slide, please. So we had to decide what to do. Should we go for another randomized trial? Should we go for some other kind of different comparison? In the end, we thought that the best way to do was a different way, basically because we really want to collect real life data. We want to know what we are doing now. We don't want really to lose this opportunity. Also because we have, as EUBREAST Network, a large and constantly growing network. We also have a massive experience from the Axana trial. in the Aksana trial, I think that most of you know about it. It's a trial evaluating different surgical techniques in patients having node positive at presentation who turn into node negative after primary systemic therapy. Within this trial, we have more than 250 open sites, and we were able to recruit more than 3,000 patients in 2 years, which is absolutely massive. And following this type of experience, we have another upcoming project, which is the Melody trial, evaluating different types of techniques of localization of non-palpable lesions. We also have the availability of REDCap. So we thought that the best way to do this type of project is to make an international single-arm, single-cohort study. Next slide, please. So again, the study design is a prospective, multi-center, international cohort study. Also, for the purpose of sample size calculation, we had to decide a primary endpoint. And I have to tell you that there was not much of a discussion about it, because we believe that the most important endpoint in this field and for this type of project should be implant loss at 3 months. Also because we have a benchmark here, considering the very, very relevant and honest publication by Shelley Potter 3 years ago in the Lancet Oncology, summarizing the experience from the UK about implant-based, basically subpectoral reconstruction. Next slide, please. And in this paper, they published data that we don't want to hear, because in that paper, the implant loss rate at 3 months was 9%, which is, I would say, higher than what we think, higher than what we hope, higher than what we expect. But that's really, that's real life data. And we have to deal with this. So we took that as benchmark, and we had our statistician calculating the sample size. By the way, I'd like to thank Edoardo Botteri for calculating the sample size. And the aim is recruiting a little bit more than 1,200 patients, which, also considering the experience that we have in the Aksana trial, I think that this is a huge number, but it's a reasonable and affordable number to reach. Next slide, please. We also want to make it easy, because still 1,200 patients is a lot of work. So we want to make it as easy as possible. Also, there was a discussion about what patients to enroll in this trial, only breast cancer patients, or to add also patients undergoing risk-reducing surgery. In the end, we decided to enroll only patients with breast cancer, because we don't want to have different populations of patients with different expectations, with probably also different background. But still, this might be also, and I say it there, the opportunity for a further project. So just focusing on women undergoing risk-reducing surgery. Next slide, please. Then we have several secondary endpoints. Obviously, and this is like opening a kind of Pandora box, because we might decide to collect endless number of variables, but still we want to make it easy. So we want to collect, obviously, all the other data concerning complications, but most important, very important, we want to collect data about patients, about quality of life, about patient satisfaction, about cosmetic outcome. And so we are going to send out questionnaires before or after surgery at different time points. We have a small dedicated subcommittee trying to define what are the right questionnaire to deliver to patients, because we don't want to overwhelm patients with an endless number of questions. Then obviously we're going to make hopefully a subgroup analysis about different type of techniques, of devices, of what happens after post-mastectomy radiation therapy, and obviously all the complications occurring in the long term. Dependent on funding availability, we might want also to increase the length of follow-up in order to evaluate also some other obviously very relevant variables concerning oncology, but this, I'm telling you, is dependent on budget availability. Next slide, please. Also, based on the lessons that we learned from the Axana trial, we feel that probably the best way to run this project is to limit the number of participating centers to 40, probably 50 centers. If we select centers recruiting, let's say 30 patients per year, so with 40, 50 centers, we should be able to collect and enroll 1,200 patients in roughly 1 year. But we want you to join, so we are going to send out the feasibility questionnaires just a couple of days after this meeting, so that each person, each institution which is interested can reply, can fill out the feasibility questionnaire, and we can hopefully collaborate within this trial. ECRF are almost done. REDCap is okay. Obviously, funding is a major issue, but we are confident that we are going to overcome this problem as well. Well, we only miss one thing. We miss a name. Next slide, please. And so it was a pleasure, because we had actually the same idea with different members, with MJ, with other people of the steering board. And we pretty much agree that this is a good name for the trial. I prepare, so International Prospective Registry on Prepectoral Reconstruction. So thank you very much once again. And so I think that we can start with the first roundtable. So it's my pleasure to invite MJ to moderate the next question. So again, everybody knows Maria João Cardoso, who is head of the breast surgery at the Champalimod Foundation in Lisbon. She's also specialty editor of the breast, and she's also PI of the Cinderella trial, evaluating the impact of artificial intelligence in the choice of oncoplastic and reconstructive procedure. Cinderella, if I may, MJ, just won a multi-million Horizon 2020 grant. So congratulations once again, MJ. And please, the stage is yours for the first roundtable about patients. So patients come first. MJ, please.
Okay. Thank you, Oreste. Thank you, Thorsten. Thank you all. It's a pleasure to be here. So the roundtable, this roundtable will include myself, then Tanya Spanik. So Tanya is the president of Europa Donna. She's here. And she's, of course, representing patients. Then we have Lucia Travado. Lucia is psycho-oncologist. She's very well known to the world of psycho-oncology. She works with me, so she's in the other part of the the center. Then Iana de Bonifacio, that all people know Iana, so I don't need to introduce her again. So Iana is a very well-known oncoplastic surgery from Sweden. Then Mahathir, you know, you heard him, so is a very good contribution. And then Rosa is an Italian young breast surgeon working with Oreste. She's very, very committed to all the projects, and it's a pleasure to have you all here. We don't have much time, so 10 minutes is not a great amount of time. So I think for the moment, the most important questions, I think, are addressed to Iana and Lucia. When we discuss this trial and many other trials, our problem is the amount of questionnaires that exists to evaluate the opinion of the patients is very difficult, because they vary enormously. So we have a publication from 2021 from Canada evaluating the type of questionnaires that we use in body image and appearance of our breast cancer patients, and only 2 or 3 are used 2 times, so in more than one study. So the variation is huge. So my question to you, Tanya, so to start, and then to Lucia maybe, is we discussed this in the first meeting that we have regarding the questionnaires to use. What you think is the most important dimension from the patient's point of view in a trial like this one? Because we can, as Iana suggested, take from each of the questionnaires a specific dimension. But the problem is, without overwhelming patients, what you think is the most important part from a patient's point of view?
Yes, thank you, first of all, for having me here on board with you and taking into account the patient's perspective on this. It's very important, and we are very aware of it, that at first place, it is the first thing is to getting the patient cured. So the oncoplastic surgery is a very important part of this treatment procedure. And as you already mentioned, there are so many available questionnaires regarding the quality of life and so-called patient-reported outcomes during the different time points of the treatment, and surgery is definitely one of the very important. So don't overwhelm the patient. That's definitely one of the things, because when they will see hundreds of questions, no one will answer them all. And what we've discussed in our previous meetings, that's very important for us to decide what actually do we want to get out of this trial. And definitely one of the things, not just the treatment, but is body image and self-body image and satisfaction, of course, with cosmetics. Maybe at first, patients won't take much care about it. But I can tell you that 5 or 10 years later, when you forget about the chemo, when you forget about all of those treatments, this is going to be very important, because now we live, I'm myself almost 15 years survivor, and today I really care about it. But maybe if you would ask me 1 year after the surgery, I wouldn't be so much worried, or I wouldn't think much about it. But now I think that if we go for longer survivorships as we have now, this is really important thing. It's not just the body image, but also the psychological side, which I'm sure Lucia can even tell us more about it.
Yes, Lucia, can you tell us what you think is most important? Because if you look, for instance, at the breast-Q reconstruction questionnaire, you have a huge amount of dimensions. If you look at the complete version, you have a huge amount of dimension. But then you are still lacking some of the most used questionnaires around, like European Quality of Life Questionnaire Global, then the URTC, the 2 companion questionnaires, the C30 and VR23. So I think if you use those more used questionnaires and then we go for the breast-Q complete, is a nightmare. So what do you think, Lucia?
Well, I think that, and thank you for the question, and it's a pleasure to be here in this group with all of you and discussing and having this stimulating discussion. I think that we have to be very critical in terms of what we want to assess, what is our aim, and what Tanya has mentioned is crucial. We need, I think one of the most important dimensions is patient satisfaction. But satisfaction is a big word. It entails functionality. How do I feel with my body? Emotions. If I'm feeling depressed, probably I'm not so satisfied. If I'm able to work and if I'm in a happy marital relationship. So we need to really those questionnaires, and that's why Oreste has mentioned that we have a subgroup to really look deep into the questionnaires that we have available and look into those questions and those modules and dimensions to see what may be relevant regarding what are the studies that have already used those measures and what are the outcomes that they give, and what are we looking forward in this particular study to obtain that also can bring us some clues about what makes a difference. We also know that, for instance, anxiety may make may ruin the effect of a surgery. So we want also to take an eye on that. It's not only about patient satisfaction, but is about also other situations that may impair the outcome of the surgery. So we want to look upon patient satisfaction, but also on some dimensions that may have a role on the outcome and the endpoints that Oreste has mentioned. So I promise you that the three of us that will be looking into the questionnaires will make the most out of shortening the version for the patients to make it sense to them the questions that we will be asking, and for the researchers team to make use of what we will be asking.
Jana, one for you, one difficult for you. That is regarding what Tanya was saying, that is along the time things are changing. So if you think about the rescue, for instance, you have a dimension regarding cancer fear. And as Tanya was saying, if we go for evaluations that are just in a certain point, we are going to have different outputs, because if at 2 years the patient's cancer fear is still high, maybe at 5 the cancer fear will be lower, and maybe the satisfaction with the body will be higher. So how are we going to solve this problem? First, we need to have money, that's for sure, because if it stops at 2 years, the problem is solved. But if we have money, and I think we can have, because this is a very important study, and we should have imagination to solve this. How do you think we can solve these secondary outcomes regarding to, should we divide in terms of time? Should we just aim for something that is in a cross moment in time? What do you think?
Thank you, MJ, for asking this very easy question. I agree completely with you that there's a lot of things that change over time. And Tanya just said that also the satisfaction with body image and with how a reconstruction actually feels will change over time. And that's actually a lucky thing, because in the beginning, you may be so focused on cancer fear that you might not be as focused on what you feel like in this kind of new body that you have got through your reconstruction. So I think it's absolutely crucial that we study long enough and then have a comparison of answers in the same individuals after 1 year, with after 3 years, and after 5 years. because otherwise we can't really tell whether we're doing a good job or not.
Yeah, I think so. Vadi, do you want to add something to this before we finalize? Because the girls are going to discuss the perfect questionnaire. And we think there's going to happen a perfect questionnaire. So what do you think?
Thank you very much for this opportunity for me to talk about this. You know, the patient side is always important because we're treating them. So the results are important. On one side, you have the, you know, disease-related things that like recurrence and survival. The other part is after a certain period of time, as you said, that the psychosocial things are just going down, and the fears are going down, and then the cosmetic, you know, concerns are coming up. So here, what I think that in the first, you know, couple of months, or let's say 1 year, most of the time it's psychosocial things are much more, you know, having a priority. But then afterwards, like, you know, after 2 years, then up to 5 years, then the satisfaction comes the more priority. So that's what I think in the, you know, couple of years, in the first, let's say 1 year or 2 years, more we should maybe concentrate on the, you know, the fears. And then maybe afterwards, because that's much more relevant and reliable to assess the outcome of what we are doing on these patients. So this is just a short, brief comment from me.
Okay, Oreste?
Yep.
We are good. This timer is
you're
frightening.
perfect.
This timer is frightening. Okay. I was expecting a shot in my head. Okay.
This red bumping like there.
Flashing.
Okay, thank you very much, MJ, and thank you very much for running this roundtable so nicely. And thank you also to the participants. It's time to move on to the second roundtable. First of all, let me tell you that we have some 200 people connected here today. I think that this is really important in order to confirm that this is a major issue and that we are on the right track, and that this study is relevant in order to learn more about this innovative technique. So now we move.
One question, because there's some question from the audience. Two related technical issues. I think we should postpone them after the next roundtable. There's one for indication. Would you like to answer to this? Is DCIS included?
Yes, DCIS is included. So we decided to exclude pure risk-reducing surgeries, but still DCIS, in my opinion, well, in our opinion, should be allowed. Also, patients undergoing mastectomy on one side for therapeutic reasons, but undergoing also contralateral, let's say, risk-reducing surgery on the other side are allowed.
Okay. Perfect. The next two questions relate to technical issues, and I think we can discuss this after the next round. Okay.
Yeah. Okay. So it is my pleasure to introduce the second roundtable and the second moderator, who is Orit Kaider-Persson. Orit is the head of breast radiation at Sheba Tel Hashomer. Orit, I think that you have some kind of superpower because you run the radiation department of breast. You basically write on the average of 1 paper per week. You're married, you're mother of 3, you're a super athlete. Probably you have, I don't know, a 36-hour day. I don't know how you can do that.
Is this recorded? Are you recording this?
But still, it will be for you a no-brainer to moderate the next session. Orit, please. Thank you.
Thank you very much. It is such a big pleasure. My colleagues at the roundtable, most of them were already introduced. Walter Weber. We have Rosa D'Amico also from the same institution as Oreste, and she's a breast surgeon. She's also participating in the Cinderella trial. We have a dear colleague Nicola Rocco, who's an oncoplastic surgeon and very well known in Italy and around the world. And we recently participated together at a conference. And we have Jana, of course, from the previous roundtable. And it is a pleasure to have you all again. So our roundtable is going to focus about radiation and reconstruction. And as you probably, most of you already know that this is a quite challenging relationship between reconstruction and radiation. Radiation causes significant toxicity, even in case of breast conservation and recurrence, and that the reconstruction is done afterwards. So I would like to ask all the panelists, because we know that different institutions have different approaches in case of post-mastectomy radiation, or in case the patient received at any stage chest wall radiation, either to the breast or for lymphoma. So surgeons, colleagues, what is your approach for breast reconstruction in case the patient ever received radiation, whether post-mastectomy or for previous breast conservation? Should we start with Walter?
Unfortunately, I have to run in a few minutes, so I'm very happy if I can say a few words first. As I disclosed earlier, I do not perform breast reconstruction myself, but the optimal type and timing of breast reconstruction in the setting of post-mastectomy radiation was actually ranked to be the first and second most important knowledge gap in the extended field of oncoplastic surgery in the 2019 project. And therefore, we took this to an own project, which we did last year, and we published it in the Breast. And there was fair agreement. Now, this is now the opinion of 200 people, right? Which is worth much more than just my own. And the overall conclusion was that autologous reconstruction is the preferred way of breast reconstruction in this setting. It can be done immediately. That was kind of a surprise, or then in a delayed immediate setting. And it should be preferred to implant-based breast reconstruction, even though the latter can be done, as everybody knows. Thank you.
Thank you. Nicola?
Yes, thank you, Orit, for your kind introduction. I'm really pleased to be here this night on behalf of Greta in replacement of Maurizio Nava. Well, yes, in my institution, we consider immediate reconstruction also for patient planned for radiation therapy following mastectomy, or patients who previously underwent radiation for breast-conserving surgery or for other reasons. We always discuss the possible reconstructive options that could be immediate versus delayed, and various types of both immediate and delayed approaches with our patients, and in the context of a shared decision-making process. And we always present the evidence of higher complication rates associated with immediate implant-based reconstruction in the setting of post-mastectomy radiotherapy compared to non-irradiated patients. And as far as prepectoral reconstruction is concerned, we know that the level of the available evidence on the impact of post-mastectomy radiotherapy on prepectoral reconstruction is not high at the moment, and evidence is also conflicting. We have some case series showing higher complication rates in prepectoral reconstruction and post-mastectomy radiotherapy. And on the other hand, also some very recent evidence, like the one coming from the University of Florence, where Itro Meattini works together with Marco Bernini and Lorenzo Orzalesi, who showed that post-mastectomy radiotherapy was not related to early or late complications or also to reconstructive failure in immediate prepectoral reconstruction. So conflicting evidence. And we also have few high-level evidence comparing prepectoral and subpectoral reconstruction in the post-mastectomy radiotherapy setting. So we need more data to guide our decision-making in immediate implant-based breast reconstruction. So at the moment, while waiting for these evidence, we base our decision making on the decision drivers we use for all women, apart from the need of post-mastectomy radiotherapy. That is the Rank-Rapi classification of breast tissue coverage at preoperative digital mammography. So we consider a prepectoral approach only for women showing a type 3 breast, that is a tissue coverage of more than 2 centimeters, often also considering a hybrid approach with the use of fat grafting. So, thank you.
Thank you. Jana?
Yeah, thank you so much, Orit. And I do agree a lot with what has already been said, especially with Nicola, your way of presenting the different types of reconstruction in the face of radiotherapy. I think every patient needs to hear that, because not all patients have the option to have an immediate autologous reconstruction. We, for example, do not have that often due to logistic difficulties in Stockholm. And not all patients have the option to go for any autologous reconstruction at all, because it's just depends on whether there's any good flap available in that patient, what she actually desires in that moment. So we do present the different options for the patient and discuss them together, and are very clear about the data concerning the complications after radiotherapy. And surprisingly, I think what is usually called the delayed immediate approach, having an implant as a kind of a babysitter, which is then sometimes mandatory change into own tissue, we see that more as an optional way, because there is surprisingly many patients who then choose to actually stick to their implant-based reconstruction despite the radiotherapy, where sometimes we surgeons maybe think that's not a perfect result, but I always try to be very clear about that. It's the patient who has to live with that breast, and it's not the surgeon who has to live with the breast. So usually we have we do implant-based reconstruction and have radiotherapy after that, and then we have a follow-up with the patient, evaluating how she feels about that, and whether we should go on with autologous reconstruction, or whether some more simple revisional surgery might be sufficient for her.
Thank you. Rosa, what is the approach in your institute?
Well, I totally agree with my colleagues, and autologous reconstruction represents the gold standard when you have irradiated tissues. We have to say that not all patients prefer this approach. When you tell them that this is a more complex surgery, the operation is longer, and so they usually ask for the simplest way to reconstruct their breast. This is why, whenever possible, we use the prepectoral approach, and we focus on the skin quality. We are going to define the damage from the previous radiotherapy and the estimated thickness of the mastectomy flap, because this is, I think, are the most important things to evaluate. If you have good skin quality and you haven't a strong damage from previous radiotherapy, you can suggest the prepectoral approach. In our institution, we always use the polyurethane foam-coated implants, and this is a solution to reduce the capsular contracture, which is higher as the other complications after previous radiotherapy. And honestly, we have good results. But of course, we are waiting for more robust data from this trial.
Yes. So I'm not a surgeon, but I tend to fully agree with your approaches that there isn't a single procedure that fits all patients, because it highly dependent on comorbidities, BMI, patients. I don't know whether you do reconstruct smoking patients or not, because some refuse to perform reconstruction because we know it increases significantly the possibility for implant failure, and especially if you add the radiation. So you need to adjust the procedure also according to the patient expectation and her body habitus, and of course the expertise of the institution. If you don't have high rate of autologous-based reconstruction, then it's less offered to the patient. So I see that Philip is online and already challenged the panel with a question. You're not radiation oncologist, but he had a question for you. We target the areas that we consider high risk for recurrences. So we target areas that we think that we might have residual disease or glandular tissue. So Philip's question to the panel is whether you assume that the target volume of radiation changes according to the position of the implant, whether it's subpectoralis or prepectoralis.
Yeah, that's a rather, we've discussed this. It does change dramatically because the prepectoral space is one primary site of recurrence, and it changes with the positioning, it changes with the size, with the shape, with everything. So I know you guys don't really like the implants when it comes to radiotherapy. So that would be my response. Can I ask one question? Who
Of
in
course.
This panel is
Can
performing?
I refuse you? Yeah.
Of course. Go ahead.
Sure,
Yes.
Walter, go ahead.
With the question, yes. Okay. How many of you guys actually perform autologous reconstruction? Nicola, are you doing it?
No, I'm not personally doing it, but we also consider autologous reconstruction for patients with post-mastectomy radiotherapy. The plastic surgeons will do flaps for us, for patients who in a shared decision-making desire to undergo this kind of procedure.
Okay, I'm just asking because in our consensus conference with 200 people, the preference was very clear, and now it sounds a bit different. So I was just wondering if maybe you're offering more the type of procedure that you can actually perform yourself to the patient for logistic and other reasons. This is my advantage. I don't do any breast reconstruction, so I just study it. So I'm playing Switzerland. I'm completely neutral, and this is the idea that came to my mind, when I just listened to you guys. That was my last word. I'm out of here. I have to go. I apologize. Bye-bye, everybody.
Thank you very much, Walter.
So I think we're over time. So Oreste and Thorsten, it's back to you.
Yes, thank you very much. I think it was a really brilliant discussion. There's one question I think that is of importance from the audience, and this is: how do you manage patients who require the mastopexy, reshaping of the skin envelope? Do you accept vertical scars, for example? Because this, I think, is a very everyday problem. The combination of pre-pack reconstruction with a modification of the skin envelope.
For whom is this question, Thorsten? Thorsten, you're muted.
To the surgeon, probably to Jana, somebody who performs the reconstructions him herself.
I can answer, or Jana, please.
Okay, I can go ahead. Well, it really depends on how much reduction of the skin envelope you're aiming at. I think if you have a large reduction, then I would rather have a dermal flap in between my prepectoral implant and the skin than just lying it under an inverted T-shaped scar. In other cases, I think probably we are using too much skin envelope reduction, because if you want to match another breast, which is a natural shape and has a grade of ptosis, then I tend to actually try to keep that ptosis. It always comes up slightly after reconstruction, but I tend to be very conservative about reducing skin if I don't absolutely have to.
Well, Thorsten, if I may, I think that there are a couple of questions directly related to the trial that I would like to address. The first one is about the possible correlation between the skin flaps and local recurrence. This is for certain a very, very relevant issue to discuss. I don't think that within this trial we're going to have enough information and enough power to address this issue. As I was mentioning during my talk, obviously the evaluation of very relevant, it goes without saying, oncological variables are dependent on the availability of funds and obviously on the length of follow-up. And then there's another question about fat grafting. So is it fat grafting allowed in the post-operative period or when we exchange tissue expander? Yes, in the sense that we want to collect real life data. So what we are doing in our daily routine. So everything is allowed, as long as it is about prepectoral reconstruction. Well, Torsten, I think that we are about to be done. It's 7 o'clock. I don't know, maybe you want to make some closing remarks?
Well,
for me.
Well, first of all, thank all of you. I think it was a really extremely interesting discussion. I think we all are very happy to have really great surgeons and experienced people on board, to have this great cooperation between the different associations. I think what we really learned was that the patient's perspective was the most important issue, and I'm very much looking forward to this to the cooperation with all of you. Thank you very much.
Well, just a few words from my side as well. Thank you again. It's been really a pleasure. It's been amazing seeing 200 people connected at this time. We are looking forward to starting this project and to collaborate together. So we are going to send out the feasibility questionnaire, and everybody who's interested, please fill out the questionnaire, and hopefully we can start collaborating together. I'd also like to thank the steering board for being here today, for contributing to the trial. I also would like to thank Philip. It was the first time ever that we had a meeting with an airborne collection. Only Philip could do that. So, and also I would like to thank the direction for this brilliant technical management of the meeting. So thank you very much once again, and see you next time.
Bye.
Thank you all.
Bye-bye. Thank you.
Bye.